Well, welcome back, everyone. I hope you've had a rewarding morning, as I have, and you were able to take in some of those interesting posters while you were having your lunch or before or after. My name is Marilyn Parker, and I'm a patient partner with the Interior Center based in Kelowna. I would like to mention that I am privileged to live on the ancestral, traditional, and unceded territory of the Syilx Nation in the Okanagan. And so as we start today, just a bit of housekeeping. It's my pleasure to introduce the afternoon panel who will speak on what considerations should be reflected on in LGBTQ2S and patient-oriented research. Our moderator is Bev Pomeroy, who is with the unit's Fraser Center, and our panelists are Jessy Dame, Nathan Lachowsky, Rowdy Reeves, Leo Rutherford, and Travis Salway. I should mention that, please note, our session is being recorded. For our Q&A session, Larry Mroz, who is with the unit's Vancouver team, and Alia Januwalla, who is with the unit's Fraser Center, will help with incoming questions, sharing them here. Remember to use the Q&A function and not the chat, Q&A please, for the bottom of your screen to submit any questions for the panel. So at this point, Bev, I will turn it over to you, and I look forward to a very wonderful presentation.
Thank you so much, Marilyn, and thank you everybody for coming and joining us at our panel today. I'm just really excited to be a part of this group. I'm Bev Pomeroy, as Marilyn mentioned. First and foremost, I go by she and they. I'm a queer female here in the Lower Mainland, and I work at the Fraser Center, which is part of the BC Support Unit partnership with SFU and Fraser Health. So I'm super privileged to be here today, and as a member of this community, to be hosting and moderating this extraordinary group is really great. I do want to acknowledge I'm here on the unceded traditional homelands of the Coast Salish peoples, and I'm actually here on the Tsawwassen First Nations land where I live. This panel really is about exploring the considerations for engaging members of our community in health research. So panelists are going to share their experiences engaging primarily gay men and cis and trans and two-spirit people in their research. And really we're going to reflect on experiences as queer members of research teams and discuss how researchers can engage with, sort of less reached members of sexual and gender minoritized communities in really meaningful ways. So what I'm going to do first really is to get the panel to introduce themselves. So I wonder if I could start maybe with Jessy.
Thank you, Bev. Hello, everyone. Thank you for having me. I'm honored to be on a panel with these amazing researchers and coworkers and colleagues. My name is Jessy Dame. I am a very proud Two-Spirit Métis certified registered nurse. I use he, him, his pronouns. I am an uninvited guest on these lands and currently reside in what we know as the West End in Vancouver. Both my parents are from Manitoba, Treaty 1 and Treaty 2 territories. So that is where my Métis heritage is from. I have worked within neonatal postpartum health, as well as within remote communities on the coast and within northern BC. I currently work as a sexual health nurse within Vancouver Coastal Health and as the Indigenous Two-Spirit Program Manager within the Community-Based Research Center, or CBRC. I'm also in my second 2.5 years into my Master's of Nursing at UBC with a focus on suicide ideation among self-identified men who have sex with men and Two-Spirit peoples. Thank you.
Thank you, Jessy. See, we're starting off with such an amazing team. Travis.
Thanks, Bev, and thanks, Jessy, for starting us off. My name is Travis. I use he, him pronouns. I wear a lot of different hats, which I think is something we're going to talk about. I'm an assistant prof in social epidemiology at Simon Fraser University, but I also work in close collaboration with partners at the BC Centre for Disease Control, where Rowdy, our patient co-lead, who will introduce himself in a moment, and I lead a collection of studies looking at how we can better meet the mental health service needs of LGBTQ2 people who are accessing sexual health services. And I also work at the Community-Based Research Center, where I've been for the last 12 years. I work there with Jessy and Nathan, and others looking at a whole range of issues. In my case, most notably, trying to understand conversion therapy practices, which are attempts to suppress unwanted same-sex attraction, and what we can do from a policy and public health perspective. And lastly, I should say I am dialing in from East Vancouver, where I am an uninvited guest on unceded territories stewarded by Coast Salish peoples, in particular Squamish, Tsleil-Waututh, and Musqueam nations. Thanks for having me.
Thank you, Travis. Well, you just led us right to Rowdy.
Hi, everyone. Thanks for having me. My name is Rowdy. As Travis said, I'm a patient partner co-lead under some of his studies that he's been doing. I was a volunteer at the Health Initiative for Men and saw firsthand how a lot of anxiety affects the clients and other people coming into the system there. So when I was given the opportunity to work with Travis and kind of look at some new methods and look into the different levels of anxiety, I was really keen to help out. And I'm really excited to be here today and give anything that I can.
Great, so glad to see you, Rowdy, and so glad that you're part of this. Leo.
Hi everyone, my name is Leo. My pronouns are he and him. I'm so glad to be here today with all of these lovely folks and all of you who have joined us on the call. I also wear a couple of different hats. I'm a PhD student at the University of Victoria and recently a CIHR fellow for the Strategy for Patient-Oriented Research traineeship. My dissertation project is a look at trans men's sexual health after they have had surgery. And within that project, I'm both going to be the researcher and a member of the community I'm conducting the research on. So yeah, very excited to be here today and chat with you all about this awesome subject. Thanks.
Great, and not last but not least, Nathan with his lovely pink shirt.
Yeah, I think we tried to coordinate outfits and accessories. Nice to see folks, and thanks everyone for choosing us as your panel. I feel very humbled to have been invited to be a part of this amazing group of folks. My name's Nathan Lachowsky. I use he, him pronouns. I'm calling in today from Lekwungen People's Territories here on Vancouver Island, Southern Vancouver Island. The Songhees, the Esquimalt, and Wasanich people who've been taking care of these lands for a long time before myself and my forefathers came to these lands. I'm Ukrainian Canadian, first generation on the Ukrainian side of that in terms of my Canadian connection. I grew up in Southern Ontario and have just progressively moved further west. And feel very lucky to have a job at the University of Victoria, which is an institution I think is really oriented towards community-based and community-engaged research, and have the privilege of working with wonderful students like Leo and many others on a variety of community-based health equity research projects with lots of intersections with queer and trans communities. So yeah, look forward to the chat today.
Great, thank you, Nathan. And you know, when we were kind of building this panel and Larry, Mroz, and Alia sort of brought this to us to kind of do this panel, we just want to acknowledge that the panel primarily has experience researching health outcomes for men who have sex with men. But we also want to steward a discussion around fostering and engaging, you know, underrepresented members of our entire community and population. That's why you have a queer female moderating. So I've got like the lesbian lens happening here. And it happens to be International Lesbian Day. So if you hear a little bit of Tegan and Sarah, Melissa Etheridge in the background, you know, don't worry. It's just because today's our day. So thanks for that. We also want to acknowledge that this is a safe space. And having said that, there may be moments in our conversation that may evoke some sort of, you know, emotional response or memory. So feel free to mute us. We won't, you know, care about that. So take a break, whatever you need to do to kind of look after yourself in this space, how to create a safe space. And if you do want to ask a question, you're uncomfortable doing that in the main chat, Alia and Larry are here to sort of moderate those questions. So if you are uncomfortable, just feel free to message Alia and Larry privately to ask them questions. We know a lot of you straight people may be a little bit uncomfortable posing your questions in the main chat box and stuff. So just know that they're there to support you in our process. So I really kind of want to start our panel today, you know, because how have certain sort of environments historically excluded the inclusion of some groups, right? Trans folks, racialized folks, and really how does that impact research and engagement? And I kind of want to start with you, Nathan, because I know you have some thoughts on this.
Yeah, thanks, Bev. I'm happy to kick us off. I mean, I think just thinking about the question to some extent, I think being excluded means in some sense even being acknowledged as existing. And I think that's been a challenge for some folks in our communities to even be seen or validated with the identities or the experiences that they have. So I think that's one thing, is that there's a lot of erasure generally, or just ignoring of who people are in our community. And that can just take the form of simple things like not asking questions about who people are partnered with and assuming they'll be partnered with one other binary gendered person. You might be assuming that there's only certain kinds of genders that someone might identify with. Yeah, so I think that's kind of one piece. I think from a kind of more institutional point of view, I think the labeling of LGBTQ or queer and trans, or however we want to kind of conceptualize this community as a vulnerable community within ethics process has meant that there's added barriers and protections in the same sense to doing research with our communities. And that sometimes made it harder or a disincentive for some folks to do this work. And I think often is the question of like, well, who is actually really governing in those ethics process, and where does community autonomy and agency sit in terms of being able to decide what research happens in their communities? I think similarly around kind of institutional pieces, age of consent has been something that continues to be a challenge. So for young people who are not of legal age of consent, to require their parents to agree for them to participate in a study about their experiences, where some of those experiences they may want to be talking about are directly related to the experience in their family of birth or their family where they're growing up, can be a real barrier to actually truly even understanding what's the full experience of that might be. So I think that's one thing. And then I think just historically, I mean, research has been used very much to address many of our communities in a pathological sense, that there was something physiologically or mentally or other kinds of illness with our communities. And so in that sense, that we're working in reparation in many ways similar to other communities that have been treated poorly. We can think about Black communities and poor ethics histories around that, Indigenous communities, and many others. So that history is something that we have to engage with in our current practice. So the last kind of piece, I think, to some extent, relates to your comment a little bit around our history and background and diversity or lack thereof on certain axes for this panel, is who are the researchers? How are our communities represented, and what parts of our communities are represented where there is power to lead research. And I think that's one of the things when we think about this work in terms of capacity building. I'm really excited when I see people like Leo interested in doing a PhD, able to engage with that, and the kinds of supports that we need to think about in terms of making the new people who we need to have in the academy more to make those pathways accessible for them. So yeah, I'll maybe leave it there.
That's great, Nathan. You've just hit on so many amazing points, which kind of actually leads me to Rowdy, like being a partner in a lot of this research as well, and knowing our history and feeling our history. How has that impacted the research that you're doing or the engagement of people within our community?
I think it definitely helps to have like people represented on the inside to kind of build that rapport and more of a connection. Because that's what's important. That's the research that we're trying to find, is that not an insider scoop, but like you definitely want the people that you can relate to helping out and getting a better answer than you might with someone that's like solely a researcher. They feel more comfortable and we can get a little more information from them, I think.
That's great, thanks. And I guess Travis, because you are involved in this research quite a bit, you and I are in a couple projects together. I'm just curious, again, looking at the sort of historical environment that we've had to sort of be in healthcare, how have you had to modify your research, as a result of that?
Yeah, I'll just comment on kind of the awkwardness of this like umbrella term, LGBTQ2S plus. Which I know we've talked about, Bev, in some of our other projects. There's a great paper by an American psychologist named Ruth Fassinger, and I think the title of the paper is something like I'd rather get wet than stand under that umbrella. And it's a reference to interviews they did with members of the LGBTQ2S community, but I put it community in quotes because it's not one community. We're talking about lots of intersecting experiences on the basis of gender and gender identity. And in particular, I've learned, although my research has primarily focused on sexual minority or gay and bisexual men, I've learned that a lot of women, a lot of trans people, and a lot of bisexual people have felt really uneasy about where those letters go under the umbrella. And so I would say I've tried to do a couple of things. One is be more specific in my research. So for instance, some of the work that Rowdy and I are doing with the Health Initiative for Men or with sexual health clinics is really tethered to services that have been tailored to gay and bisexual men. And while I think those clinics and our programs are doing a better job of expanding what that scope of inclusion looks like, we have a long way to go, and we need to be attentive to that, acknowledging, and maybe Leo or Jessy will have things to add on, you know, when sexual health services might not, like a one-size-fits-all approach might not work if we're talking about trans patients or we're talking about Indigenous or Two-Spirit people. Like, how do we actually need to rethink or critically reconsider some of our interventions that maybe were set up to serve a particular subset of that LGBTQ2S kind of spectrum?
That's great, Travis. And that kind of leads me to you, Leo, to kind of touch on that a little bit, like Travis mentioned. Like, how have you had to modify your research? Like, what does that look like?
Well, I'm new in the world of research. I'm a trainee now just as a PhD student. And yeah, for me, I've always been set on the idea of community-based and patient-oriented research. I've always valued the knowledge that my community has and consider that very important in developing research questions and sort of leading methodology that I'm working on. But, you know, in the past, research about trans people has been conducted primarily by cisgender or non-transgender people, and it's been research that's been about us rather than with us or for us. And so we are seeing like a shift, I think, these days, and people recognizing, as a kind of, as Rowdy was saying, that like people who are involved and have lived experience have a lot to give to researchers and a lot of information that can shape the way research is conducted that makes it more appropriate for the community and gives better results.
That's great, Leo. And Jessy, like, you're on the front lines of a lot of the work that we're talking about. So sort of similarly to you, like, how have you been able to navigate that?
Yeah, I mean, now that I'm still working with patients multiple times a week, and then in the research realm, like wearing the multiple hats and navigating it, I think a huge thing that I'm noticing more and more due to this history of exclusion is that we've created a base of research on cis hetero white folks, so that we've created this view as that those folks are the norm, and we're always comparing people from the queer community or indigenous community, BIPOC community to this now norm, and how that results in further stigmatization and stereotypes. So it really makes me think that, like, when we're comparing folks, I reflect on, why are we comparing folks? Who are we comparing them to? Especially in healthcare, when access should be equal to all, why are we comparing to white, cis, hetero folks that have very different barriers and limitations to folks that access the sexual health clinic that I work at?
And I guess that kind of lends me to, you know, talk about a little bit about the fundamental principles of inclusion for the work that we're all doing. I mean, you touched on a little bit there, Jessy, with equal access, and, you know, Leo and Rowdy talking about, you know, the community itself determining the questions and what their priorities are. So I'm just kind of wondering, you know, Rowdy, like, what are from your experience some fundamental principles of inclusion that are needed for this type of work?
I think just like empathy and like really being like able to connect on that kind of level. Like, you want to give them a sense that they're like make them in the most comfortable space possible so you can get a genuine answer, because a lot of the time when you are like delving into some of these questions, they do get kind of clinical and they aren't really going to give you the most like heartfelt answer, I guess. And that's, I think, what we really need is something that where you can hear more about what they're actually saying rather than like body language and all that. So I think like that's a big part, is just creating an empathetic, that kind of environment. And
I know, Nathan, when we were having some discussions before, because there has been a lot of sort of activity around the new BC C2C language guide, which, you know, I was kind of holding up and revering. And you made a really interesting comment in our conversations about focusing, it's not on the language, it's about, you know, the words more about, it's less about the words and more about the action. And I wonder if you can speak to that, because I think we do get wrapped up in words. I know I get asked to do presentations on pronouns and all kinds of different things. And I'm wondering if you can speak to that, you know, when you're considering principles of inclusion.
Yeah, I was nervous there for a second, Bev. I wasn't sure exactly what I said, but that part I can definitely talk to. And I mean, I see some of the chat around kind of some of these aspects of maybe the acronym aspect of using. And I think, I mean, just to, I guess, push back for a little bit of devil's advocate is, I mean, I think that there's an importance of thinking about the role of us being divided and separated. And I say that very broadly in terms of whatever access, but I think part of what we need in terms of social change is to work across difference and thinking about how some of these can be tools for that. And I don't think that any tool is necessarily always good and always bad. But I think to the point of language, I think there is a highly evolving culture of what is acceptable and not acceptable. And I think sometimes we see that in very kind of exact or like universal truths, when in fact, I think there's quite a bit of difference when I think about some of the projects we've engaged across age generations and cohorts. There's not a language solution to working across some of those. And that's okay. But it's, I think, important to make sure you have those conversations. And I guess the kind of the broader piece is thinking really about process as opposed to like the technocratic aspect of like, if I do all of this, then I'm a good inclusive researcher, or I'm a good inclusive patient partner or liaison, or whatever role it is that people are in. And I think it's not about the performativity of inclusion. It really is, I think, about like really thinking through the emotional aspect of what it is that you're doing and how are you engaging in that in terms of your heart. And I think that aspect that like we often are taught in a lot of Western science approach to leave that behind, that it's a form of bias, that it confounds the relationships that we're looking at. And I guess in the journeys that I've been on with many folks in community and in the academy have really taught me to push back against that kind of messaging, and that we need to create space for that, because I do think it's about working differently. And if we just keep doing exactly what we were taught to do, we'll just keep replicating the same things that have led us to where we are today.
Well, there's a quote in the first 15 minutes of our panel people can use for sure. And so Jessy, for you, because you do work, you know, within the community itself and on the front lines as a nurse, you know, I'm curious from your perspective, you know, some of these fundamental principles of inclusion, because you see it and you're in it and you're doing it every day.
I think I can echo what Rowdy was saying, is just like empathy, understanding that, especially in healthcare and nurses that come in with experience from a variety of things. And I think from the healthcare's perspective, I've experienced the harm that can result from people coming in with their own judgments and their own, like healthcare professionals coming in with their own judgments and their own ideas of the way certain things can be, and kind of losing that empathetic, non-judgmental standpoint. So it's like coming from a base of empathy that we are all equals. And we all deserve equal and equitable access. That's not currently occurring, but that's what we all deserve. So coming from that place of everybody should have access here, but even in a queer-focused sexual health clinic downtown, we still experience, unfortunately, exclusions criteria. I mean, I'll put it on the spot, but even the Health Initiative for Men, the name the Health Initiative for Men has its own limitations, right? And now as we change and the language is changing, we realize that healthcare likes things to be defined and like this way or that way. But as we continue to grow, for a perfect example, as a two-spirit person, there is no exact definition of my identity. And that's the beauty of it, but healthcare doesn't like that. They don't like that I don't conform, or I don't want to conform to this exact definition, because it's ever changing. My identity is quite different than my best friend Leah, who's also two-spirit on the other side of the country. So in healthcare, we demand a definition, but I say push back and don't define yourself unless you want to.
Good
And we
advice,
shouldn't
good
have to
advice.
define ourselves to access services. We should not have to give any definition to access services.
Yeah, how true is that? Very true. And Leo, just, I know even within our own community, you know, we need to have more inclusion, you know, within our community. And I wonder if you can speak to that a little bit.
Yeah, listening to everyone talk, I really wanted to mention, for me, the importance of capacity building, which Nate kind of touched on, but like there's a lot of barriers that people face to either being involved in research or like becoming the researcher. And I'm someone who's very lucky to like have access to someone like Nate who can support me and foster me to become someone in that position. But especially trans people face a lot of challenges to get involved and to either just be someone at the table giving feedback to researchers. There can be challenges there, or you know, getting involved in a higher level. There's just I think a lot of levels to the question of like how to make this all more inclusive for folks. That people, yeah, may want to just consider like who is at the table and like who's not represented, basically. Yeah.
Yeah, that's great. And I just kind of shifting a little bit, Travis, sort of on this sort of theme, but you know, there's been changes happening right in the landscape for meaningful research within our community and our population. Or I kind of question, have there been changes? You know, what has your experience been? You know, you've been doing this for a little bit. You're pretty experienced, I think. No, you are. You know, so what recent changes have happened to change the landscape, and you know, what has your experience been?
Yeah, I'll highlight just two recent developments that I think are really encouraging that we should be paying attention to. So one is that some point in the early part of 2019, the federal government had a look at what policies and legislation had been introduced to secure the rights and protections of safety for LGBTQ2S Canadians. And they kind of held this in contrast to epidemiological portraits that many of us have been looking at for years, which show that despite these really impressive legal gains, things like access to same-sex marriage, protection against discrimination, there are still dramatically higher rates of various health concerns that disproportionately affect us as queer and trans and two-spirit people. Things like suicide, depression and anxiety, problematic substance use, HIV, sexually transmitted infections, barriers to accessing primary care, things like this. And so they held a hearing. They did a study that lasted several months, and they talked to I believe over 50 expert witnesses, and kind of pulled together all their data and came up with some concrete recommendations that the federal government could take. Some of them are really directly related to data and research. They really had scathing reviews for how Canada has fallen behind other countries in like the United States in particular in how we collect data on LGBTQ2S people. We were an innovator in this in the early 2000s because we added a sexual orientation measure to the Canadian Community Health Survey. But in the subsequent 18 years, very little happened on that front. So there was really an explicit push to have more inclusive measures in all federally funded surveys. And I think we can interpret that to mean all of us doing research with a quote unquote general population can do a better job at identifying subgroups of LGBTQ2S or sexual and gender minorities. They also pushed for expanded funding for LGBTQ2S focused projects, and we're starting to see that materialize. The other thing I'll mention is that many of you will be familiar with SGBA, or sex and gender-based analyses, that CIHR has encouraged researchers to use for quite some time. And we're starting to see a shift, particularly led by folks at the Institute of Gender and Health, to really come up with a more nuanced, complex understanding of what SGBA looks like. Kind of thinking along the lines of what Jessy said earlier about how do we move away from these very binary and kind of fixed categories to think about more dynamic things like two-spirit, like intersections between gender, trans status, so sex at birth, and sexual orientation. And I'm starting to see examples of this, and I think if you watch the IGH website, there will be some more specific pointers coming out on that.
That's just so fascinating to me, and I know everybody here has such a wealth of experience. And one thing that I know that we all, I think, recognize, and maybe Leo, I'll go to you sort of to talk about this, is, you know, speak to sort of role divisions for all of us, because we all identify as being part of the community, as I do. I am both a patient partner, I'm employed as a patient engagement specialist, you know, I'm part of research teams, and we talk about the sort of patient initiated. We are at a POR, patient-oriented research conference. You know, we wear more than two hats. We tend to wear, like, you know, baker's dozen. So what has that been like for you as you're kind of newly getting into this role of researcher as well?
Yeah, thanks, Bev. That's a really good question. Short story, it's been fun. I like kind of upsetting the traditional status quo, which is that researcher and participant, or, you know, researcher and community should be separate and distinct from one another. And like everyone else is kind of already saying it, there is so much overlap involved in people's identities and in the roles that they take on various research projects. Yeah, but I wasn't prepared kind of for the division of roles that was expected or like prescribed when I was looking into grants and such for patient-oriented research, because for me it feels very natural for someone to be both a community member and a researcher. And so yeah, I think I hope going forward that that more people are able to like be in those dual role positions, because I think it really adds a lot of nuance to research, and also it does again kind of disrupt the idea that people have like one identity that is very specific and within a category and does not overlap with any other areas of research or their work. Yeah.
No, that's great. It's so important to understand. And Rowdy, maybe the same question to you. You know, now that you're entering in this world as well, you know, patient partner, researcher, you know, and delving into some of these projects, how has that been for you, sort of those divisions, or learning about those divisions in traditional research that maybe in the research within our community may or may not be a good model?
Yeah, like Leo said, I think it's just super important to, like, I also came into it as a patient and then a patient partner, so it just kind of flowed for me, and it really makes sense to have this inclusion from the community. And even for me, like, especially like focusing on different subgroups in like the overall community, like I'm a very privileged white cis male, like, and I feel like I do have something to give, but we definitely need to include these patients and their perspectives in the research that's coming up, because it's going to directly affect them. And I think like inclusion is super important in that kind of aspect, and get as many patient partners as we can. It just makes the most sense to me.
Yeah, that's great, Rowdy. Yeah, I'm with you. Yay, patient partners. You know, it's so important. So I'm just gonna, you know, sort of, there's been a historical precedence for strong community engagement, right, in our community. And I just want to acknowledge all the amazing stewards and advocates that came, you know, along way before we were here, that have really helped pave the way for a lot of us to be able to enter into this work in traditional academia, and actually be able to be here today and have this panel on a provincial research conference, right? So there's a lot of work that's been done before us. And so Nathan, just thinking about that, you know, what are the challenges or the facilitators of successfully building bridges with other stakeholders? Because this is academia. These are health decision makers, healthcare providers. So, you know, what are those challenges, but also what are the facilitators for that?
Yeah, I mean, I think on the facilitator side, I really think that relationships are the key. Do you know what I mean? And I mean, it takes time to build relationships or repair relationships, to establish enough trust and like history for those to go well. So, I mean, I think that's kind of one thing I think as we kind of bridge to new communities or different communities than we've been working with. I mean, I think on the barrier side, there's this acknowledging the progress and acknowledging the importance of the conversation today. I still think a lot about the traditional power systems that decide who gets the money, do you know what I mean, and what priorities get funded. And I think when I think about a lot of LGBTQ health work, at least in my area of work, I mean, it is largely public health priorities. Issues with HIV and STIs, issues with differential chronic disease, issues with smoking. Do you know what I mean? I think those things aren't necessarily, they might be priorities of some folks in the community for sure, but there are also things that have in many ways been kind of articulated as the reason why it's important to focus on these communities. That, and I think that like making sure that we're attentive to that aspect of like what is setting the priorities for the kind of research agenda is important. And then I think the other piece is also thinking to the facilitator side around how we do that. But then I think the other piece that we really need to work on is how do we change the resourcing structures? Because as of right now, things largely still flow in very traditional ways. And so how do we think about getting more resources to have communities be able to commission researchers to do work with them, as opposed to having a, do you know what I mean? And I think there's opportunities and I think examples of that. And CBRC is one organization that I think has worked really hard because of the help and assistance of a lot of great people over the years to try and get into a point where they can lead their own work. And so I think we need more of that. And I think we need more models that demonstrate the value and impact of working in that way.
Yeah, it's really important. I'm pretty sure there's some staff and people from funders here watching the panel. So that's good to note with that. And, you know, Jessy, one thing that I know, you know, my own experience of trying to get healthcare or having healthcare as a queer, you know, female, this is kind of like a weird question, but I'm just like, why should researchers and healthcare practitioners care about being sensitive and inclusive to our community? You know, especially in settings that don't specialize in care. We've talked about different organizations that are very specific, but just in general, like, why should they be sensitive and inclusive to that and to us in those settings, those healthcare settings?
I think the one way to easily put it is that because the harm that can result from one like couple second experience can last a lifetime. Going back to your previous question just about wearing many hats. So like a lot of us, especially this panel, wear many hats. And my primary area of focus is two-spirit men who have sex with men, which is also my identity. So not only am I trying to build a path to research in this area, I'm also combating a lot of my own internal items and basically putting them all out on paper. So then the research that's coming from myself or other folks like me, it's like not only are we advocating for our research, we're also advocating for our own identities in a sense, right? To validate, but yet I'm going to researchers and healthcare professionals to validate this research, but also who I am in my experience. So that is like a huge, I think, a barrier to creating connections with a number of folks, just because we don't really always see that folks who are a part of the community, that work in the community, that research community, are doing wearing many hats in that way. But primarily in healthcare settings, like in the NICU, like I work in a neonatal intensive care unit and have had a number of queer parents or folks that identify out of the binary, and seeing assumptions made, or like where's like perfect example is like, oh, who's that I've heard who's going to be the mom in a pair of gay dads, and that kind of question, like in 2020 you'd think that it would be gone, but it's not, and then the lasting effects on that can be detrimental for the families.
Yeah, so important. I mean, I have 3 kids, you know, one that had extensive healthcare issues. So you can imagine every time myself and my spouse were in the room, it's, oh, is this your aunt, to one of us in there. So I think that's important, Jessy, and I appreciate your work that you do in NICU, because it's not a you know, an easy place to work. So Travis, I don't know, like, what about those who feel discomfort when they're being asked to change their practice to be inclusive of our community? Because it is uncomfortable, and we've all kind of butt up against that and have run into people where we are trying to sort of inform their you know, sort of way of caring, or even within research around that. So what about that discomfort?
Yeah, that's a great question. I think like we don't do ourselves any favors by pretending like everyone is completely on board with adopting inclusive practices. I think we have to acknowledge that people come from very different places and times and social settings in which they may not have had much experience or opportunity to learn the kinds of principles that my co-panelists are outlining. I think one concept that's really useful and hopefully familiar to everyone in healthcare, which I've heard Jessy talk about before, is that of patient safety. So I think it's useful when people are expressing some discomfort or uncertainty. In some of my work in public health, I've seen this in particular around issues around inclusive forms and data collection for trans people, where we're asking them to really use meaningful and specific measures relating to things like gender identity, sex at birth, trans status or history, is to remind people that if we are not actually interrogating that discomfort, if we're not actually sitting down and asking, like, where does this come from and how do I dismantle it, you risk patient safety. You risk patient safety because you're collecting bad information, or you risk patient safety for reasons that Jessy outlined. You've actually deterred people from accessing the best forms of care because they don't trust that coming to a healthcare setting, they're going to be heard and seen and included. So I find generally framing it as an issue of patient safety, patient engagement and care is useful. More practically speaking, Bev, you and I are involved with a fabulous project out of UBC called Diversity and Patient Engagement, and some of the leads from that project I saw are here with us. Hi, Erin and Iva. Maybe in the chat we can include a link to this. But what we've done with what they've called the tapestry teams is they've looked at, I believe, 6 different equity-seeking populations, one of whom are LGBTQ2S people, and really asked, how do we come up with some concrete guidance, short videos that help researchers and healthcare providers figure out strategies for making an inclusive and safe environment. So I encourage folks to check that out as one kind of practical tool.
That's great, Travis. Nice plug there, by the way. So hopefully Erin or Iva will put that up in the chat box. But it's important. But even that project was a difficult project, right? It's like, how do you decide what's important to share, right? So that we can help people sort of navigate. And I guess for me, Rowdy, like, I'm just kind of curious, from your perspective, what is inclusion and safety for our community actually look like in practice? What does it look like when it is safe, when it is inclusive, sort of in the experiences that you've had, but also in the work that you're doing in research?
Big question. I think just inclusion and safety looks like freedom, I guess. Like, you just feel safe enough to disclose, feel safe enough to be who you are, and give, again, those genuine answers, and just, yeah, be as open and good as you can. Hopefully we can create these spaces that they are able to disclose all this information and feel that it is going to do them help, and yeah, create open environments. But I'm not hopefully certain we can do that in the future.
That's great. And I guess, Jessy, that's for you as well. Like, when we don't see it, right? So, talk a little bit about the anxiety in health services that may reflect, underlying anxiety or distress related to experiences of discrimination. I know that that's something that's important to you.
Yeah, I think there's, we all as healthcare providers or researchers need an understanding that folks come in maybe with anxiety or fear from previous experiences or from hearing from friends' experiences. So creating a space that is inclusive and safe is extremely important. But what that is or what that looks like, I don't know if I don't know if we have one yet. And I think it's very individualistic. So I can't explain what it is to you. I can only explain to you what it is for me, which is very different than a lot of folks. But I think going back to what Rowdy said earlier, is just creating a space for open dialogue is key, and just open hands and open hands and closed mouth is a thing that we say to provide the forum and opportunity for people to speak instead of speaking for. It's speaking with. So in a healthcare sexual health setting, we talk about many things, sexual practices and things that folks don't always feel comfortable sharing, but it can be very important for types of testing or risk factors or different things that like lubricants and things that could help reduce risk or reduce injury. So having those conversations, creating a space for open, honest communication is so key. But also in the back of my mind, I'm always reminded that I don't know exactly what this patient is coming in with, their experience historically. So being open is so key.
And I guess, Leo, that kind of leads me to ask, like, how do we acknowledge, patients and even ourselves where we're coming in with some anxiety or distrust of healthcare workers because of our experiences, within the community itself? And I would say that includes distrust of research and researchers. So how do we acknowledge our fellow patients or patient partners that do have that anxiety or distrust?
Yeah, I mean, obviously I speak so much about the trans community because that's where my work lies, but there's so much mistrust of researchers within my community because of historical wrongdoings. And I mean, as Jessy kind of mentioned, and of course that was in a clinical setting, but it also applies to research, that the principle of like first doing no harm to communities that you're working with is something that I think is really important. And of course, something that patient-oriented research can address, and working with communities to develop research priorities and such. But yeah, trans people have experienced researchers sort of not interpreting findings in a correct way, things that harm them and such from various research findings. So I think people are a bit leery sometimes of getting involved in research because of that. Again, a plug for doing patient-oriented research as a way to sort of start to rectify the wrongdoings that have been done to the community. Yeah.
Okay, great. I know we're going to have some questions from other people too, but I just kind of want to end with giving everybody an opportunity to sort of answer this question, not necessarily quickly, but, sort of to end our panel today. We'll start with you, Nathan. What advice would you give to queer and trans communities and our communities who want to do this work?
I don't know if I have a great answer to that specific piece. I mean, I kind of think, I guess one of the things that has just been ruminating with me over the last few questions is like, how do we approach this? And I think sometimes we focus on like the direct moments of conflict or negativity. And I do think sometimes that we need all of the approaches that we use, but we need to think about the fact that a lot of these experiences are shaped by social conditioning and shaped by during a lot of larger things that are going on in society. And that I think we need to think creatively about how we don't just go to queer and trans communities to solve these problems, but that we really think about how we work further upstream in terms of how we talk about gender, how we talk about sex, how we talk about sexual orientation and diversity. And that those kinds of things will then inevitably feed into how we educate people, how we educate healthcare providers, what healthcare experiences look like. So I think that we can lead from within those systems, absolutely. But I think that we also need to work from the outside. And I guess if folks are interested in this work, I would guess the brief advice I would give is to find somebody you trust or you think you can trust and to start a conversation.
That's great advice. Jessy, what about you? What advice would you give?
Yeah, I think the first thing that jumps out to me with that question is just support. Like I spoke to earlier, like coming into this academia fighting ring, in my mind and from my experience, it can be tough, and working in healthcare as well, because you're, as I said, navigating your research, but it's also a part of you, right? So having a strong support system, like many of these people on my call on this panel that I can call friends, is so important to support you on your own healing journey, but also on your research. So a support network. And thankfully, I think back to one of your other questions is that we are having some growth in queer, two-spirit, LGBTQ plus researchers. So we're like, that is a big change. We're seeing a few. I still don't have a supervisor that identifies to me, but there's starting to be some folks. So we're seeing an increase at least.
That's great. Travis, what are your words of wisdom?
Well, I'll just say I like what all of the other panelists have said. And one point that I will add or maybe re-emphasize is just, I think many of us, I don't want to speak for other people, like really are able to do the collaborative work with trans and queer and two-spirit communities because we focus on relationships first. And I think it's awkward because when we're writing a health research funding proposal, we're putting the outcome first. We're saying this is what we hope to achieve. But in order to do that research, you have to follow a process that's respectful and meaningful and inclusive in all the ways we've just discussed. And generally, I've found that the most rewarding projects and the ones that actually produce the best results are the ones that are really attentive to those relationships. Someone had asked earlier about, how do you move from tokenizing diversity to actually, doing this work in a way that respects the diversity? And I think it just takes a long time. Community-based research means you spend a lot of time with your community partners. Sometimes it's very painful. I've had plenty of times where my community partners, especially where we don't have a shared identity, will call me out for doing things that are offensive or inappropriate. And that takes a lot of acknowledging harm and going back to square one and rebuilding relationships. So it's a very long process that doesn't fit within a 3-year CIHR funded cycle. I do have, it sounds like I'm just here to plug lots of initiatives, but I am really proud of a checklist that we developed at the Community-Based Research Center called Grow and Lift. And Grow and Lift is really, it's not a checklist where you check everything off. It's actually a communication tool. So it's for community partners, community organizations who are understandably a little bit anxious about working with academic researchers. And it's for academic researchers and trainees who don't want to go into a community collaboration and cause harm. So it's actually just it's 8 points of discussion that researchers and community partners can have so that they are respecting the relationship first rather than the results first.
I love that, Travis. Those are great tools to be sharing. And I guess I'm going to kind of give last word to Rowdy. What advice would you give to your community or to someone in your community who wants to enter into this kind of work?
I think, well, everyone's made really good points just about being open and how it's going to be a process. It's hard to kind of put the onus on the patient, but even what I did was I asked, I was just a patient at the Health Initiative for Men, and I asked if they need volunteers, and I asked if they're ever looking for research assistance or anything. And so if you were comfortable in the community and you're stable, then just reach out, and look for people that you trust and can feel that you can have that open discussion with. And that's probably the best way to make your voice heard and get your opinion voiced,
That's a great, and actually I lied. Leo, you get the last word. What would your advice be?
Oh, amazing. Thanks, Bev. Yeah, I mean, I agree with what everyone has already said so far. In terms of relationships and that sort of thing, I often think about why people choose to get involved in particular research projects, and I'm always asking the question of other researchers, why you? Why are you the one who should be doing this? Are you in a relationship with a community that has asked you to, or that has identified a clear need that you're in the position to address? And if not, maybe consider, is there someone else who's better suited for the project? And then just making sure that the right people can be at the table, who's been excluded from the work in the past, and how can you include them in the future?
Those are just such wise words. And Marilyn, I'll kind of hand it back to you, but I just want to say thank you so much. Leo, Rowdy, Jessy, Nathan, and Travis. This has really been an extraordinary conversation with everybody today. And Marilyn or Larry or Alia, have there been any questions that you want to, profile or highlight for us?
There have been a few questions. I'm going to defer, first of all, to the two who have been watching the chat board very closely. It's just been such wonderful examples that have been provided, but I know we do have some questions.
Yeah, thank you. So there have been a lot of great questions, and some of them have been partly answered. And I'm just going to take one that I think was hadn't necessarily been touched on yet. And this is a question that reads, I am the mom of a child that is curious and discovering their own gender. It has awakened me to the importance of language and also the dominance of heteronormative language in healthcare. I am curious about how we might address this in our education programs. What things have you seen that have worked with healthcare trainees? Long question.
Yeah, Nathan, you want to, maybe Nathan or Travis?
Yeah, I mean, I think that part of my closing comments were actually inspired a bit by that person's comments, because I do think that part of it to me is about, like, I mean, this is the reality of people's lives when they have kids, and then they're confronted with these things, and there's not a lot out there for them in terms of support. So I do think that the part of this is about thinking more broadly than just how do we do that with healthcare providers, how do we do that with educators, how do we do that with anyone that we're training in any kind of educational setting, but also just more broadly. And I mean, I do think it starts with role modeling, do you know what I mean? And I think that as best we can, we do that work ourselves, and explain why we're doing that is the other piece. Yeah.
Travis, do you have anything to add to that?
Actually, I don't mean to put Jessy on the spot, but I want to defer my suggestions to Jessy, because I know Jessy has been working on some really amazing collaborative work at the CBRC and elsewhere, documenting experiences of discrimination in healthcare. And like, my feeling is like, we need better training opportunities, but we also need to be very real and accountable about where discrimination still occurs.
Yeah, Jessy, take it away.
Thank you, Travis. I mean, I can one resource for the person who asked the question is, I mean, Trans Care BC has great resources on gender neutral language, or approaching the conversations for healthcare providers, but also for anybody who wants, and they're free online. Gendered language is rampant in healthcare. It is all over the place, and it's a conversation that I'm having with the College of Nurses and the union, our provincial union, just about how can we make it a safer environment for our gender, like, non-binary nurses, but also for our patients. And I think an important factor that we have is having the conversations, wearing pins, or this is a he, him, his pin, but having conversations with folks and normalizing that it's okay to ask. I think what I've experienced in my professional practice is the folks who get offended when I ask are typically folks who typically folks who are cis, hetero, and are like, how dare you ask me? There's still this like anger towards asking, and that's what we need to challenge, to normalize having open conversations. Personally, my nephew is 9, and my dad is always like, do you have any girls at school? Do you have any crushes on girls at school? And I'm like, Dad, why can't we just say, do you like anybody at school? Like, changing that, just completely neutrality. You don't have to add a gender onto it. And as we slowly move forward, I think it'll be safer if we're very cognizant of the languages that or the words that we're using.
Yeah, not easy, but it's nice that we're all, going down that path and doing the work. And we're going to make mistakes, but along the way, but we're doing the work. So thank you for that, Jessy. Marilyn, I guess I turn it back to you as being the host. Sorry, somebody else want to say something?
Well, I was just going to go back to the conversation that discomfort is where we grow the most, right? And these conversations are uncomfortable, especially because we're raised in a society that tells us we're supposed to be a certain way. So that discomfort, we need to normalize, like we spoke to earlier, and then through that, we can get to the bottom of where it comes from and then get rid of it. So that discomfort is normal, but you have to move through it, and reaching out to folks like us or other services is the best way.
Well, I think you've given me an idea. I think we need to have like a day conference just on research in this topic coming up soon. Marilyn, go ahead. It's all over to you.
Jessy, it was a great last response to the questions. First of all, I'm so enriched by being in the room with all of you. It's something we all need to talk about more often and to have these discussions. And I'm so encouraged by the BC support for including us on the program today. So thank you, Bev, for your excellent moderation of the panel. You asked some really rich questions. Thank you to Jessy, Nathan, Rowdy, Leo, and Travis for all your excellent and enriching discussions that we've learned so much from. It's now time to take a stretch break, folks. Remember that in 5 minutes, there's going to be 5 informal hallway chats on some specific topics. And everyone is welcome to drop in and participate, making some new connections. The details and the links are on the Open Water Conference website. And at 2:30, you'll join the breakout session of your choice, and we'll come back together for the plenary at 3:30. So thank you again, everyone. Enjoy the rest of your conference, and I look forward to seeing you in another chat room. Bye.